So that's a great question, whether or not patients who present with hormone-sensitive, newly diagnosed metastatic disease should all receive chemotherapy in addition to the androgen deprivation therapy. There are 3 clinical trials that have been done, one referred to as a French study, a second referred to as the Charted, and the third, the Stampede. All of them have some slightly different mix about them in terms of the type of patients, the volume of disease of the patients, and whether they subset. So for example, the French study looked at high and low volume. The Charted study looked at high and low volume. The Stampede study did not segregate that out. In the studies that did look, and let's focus primarily on Charted, there was a difference. Overall, the study was positive, and it added about a year of overall survival for those patients who had combination of chemotherapy and androgen deprivation. However, when they did further follow-up and looking at the subset of patients, which was prescribed in the trial from the design at the beginning, there was a major difference. The patients with high volume disease, so those with 4 or more bony metastases, including one outside of the axial skeleton, or soft tissue, such as lung or liver, those patients had a significant benefit, maybe as much as 19 months survival advantage when using combination docetaxel with ADT. On the other hand, the low volume patients did not seem to have that type of benefit, and in fact, there was no significant difference. So in my opinion, I think there are patients who present with less disease burden, lower volume, perhaps the biology of the tumor is different. If you take into account potential toxicity from the chemotherapy and that trade-off, I think that you could defer the use of chemotherapy, and for those patients who progress beyond androgen deprivation, at that time you can offer them chemotherapy more selectively than just giving sort of a one-size-fits-all to your patients. So in summary, I think the high volume patients clearly benefit. The lower volume patients might, with the trade-off being side effects, and there's certainly data from the Charted study to suggest that you can wait and give the chemotherapy if they don't respond or if they progress through the androgen deprivation. In those studies, the 3 studies I mentioned, there were even differences in those who were on sort of the androgen-only arm in terms of the number of patients who would actually go on to receive chemotherapy if they failed. And so in those studies, such as the French study, where I think 80% of patients who progressed through androgen therapy alone were then given chemotherapy, there wasn't really, the type of difference that we're talking about. In the Charted study, only a small percentage of men who progressed on androgen therapy alone were given chemo. So I don't think it's an all or nothing decision. I think it's really one of timing. And so for high volume, yes, offer it up front. For low volume patients, I think you can have that conversation with them, risk and benefit, but a more deferred approach where the chemotherapy could be added if they progress would be my preferred approach.